Good to have you all here. It's my honor to welcome each and every one of you on behalf of the Addiction Treatment and Recovery Caucus. I'm excited for our first official event in collaboration with the Congressional Black Caucus, and I know that some of my colleagues from that caucus are going to join us. The ATR caucus has a history of strong bipartisan support, and this year, in our 20th year of forming, recognizing and working hard to make certain we stamp out whatever policy, promote whatever policy is essential to stamp out the stigma and to make certain that we respond to the illness of addiction and treat it accordingly. I'm proud to serve in that caucus leadership as co-chair, along with my fellow co-chair on the Republican side of the aisle, Congressman David Joyce, and our vice chair, Dean and Chavez DeReamer. I thank you all for making this briefing possible. There are many who have been involved. Special thanks really have to be shared with the Overdose Prevention Initiative at the Global Health Advocacy Incubator. And I thank Yolanda, who's seated right to my left, Yolanda Richardson, and Libby Jones. Libby is over here, who's helped us stage in many of these forums. Thank you, gentlemen, for the help. Finally, we have our mics so the voices can be heard. So I thank both Libby and Yolanda for their role in today's forum. I also want to thank all of today's panelists. Dr. Jerome Adams, who has shown himself to be a real leader in this space, as has Dr. Kima Taylor, Tracy Gardner, and Bill Rutherford. So thank you one and all for being such an excellent panel. Thank you for sharing with us your expertise and your insights into this critically important issue. Today's discussion will examine inequities. Inequities in the overdose crisis, specifically those inequities and the impact they have on Americans of color and certainly the Black community. As we know, there's no corner of the country that has escaped the effects of this overdose crisis. While we're seeing data that overdose deaths in the U.S. may, believe it or not, be declining for the first time in years, we're still seeing an increase in overdose deaths in Black Americans. We also know that Black communities face some of the greatest barriers in terms of access to effective treatment. Last Congress, we took a major step forward in addressing our overdose epidemic by passing my Mainstreaming Addiction Treatment Act into law. Proud to have authored that because I thought there needed to be reforms in that medication assistance treatment arena. This eliminated the outdated barriers that prevent more people in need from having access to buprenorphine, a life-saving drug for addiction treatment. Black patients are 77% less likely to receive buprenorphine, one of the most effective treatments for addiction. I think that's worth repeating. Black patients were 77% less likely to receive buprenorphine, one of the most effective treatments for addiction. By passing this law, we are vastly expanding access to addiction medicine and moving us toward a system of treatment on demand for those struggling with addiction. However, even with this progress, we know that treatment gaps remain, and we must ensure that as we make progress, that it is equitable and that it indeed reaches all people. Another issue that I'm focused on is passing the Reentry Act. Too often, our justice system is a revolving door for those struggling with addiction and mental health issues. Many individuals in our nation's jails and prisons are struggling with a substance use disorder, and many have co-occurring mental health conditions and physical health conditions as well. We know that incarceration for crimes related to substance use and possession disproportionately impact upon our Black community. The need for uninterrupted and comprehensive coverage for individuals prior to release from incarceration has never been more critical, and the inability of Medicaid to cover otherwise eligible patients or individuals has unintentionally stood in the way, creating burdens for law enforcement and obstacles for individuals who truly need care. Currently, federal statute prohibits any form of federal health coverage for incarcerated individuals except under very limited circumstances. In most states, Medicaid coverage is immediately terminated when someone is sent to a correctional setting. I think it's a harsh creation. This creates a serious coverage gap when individuals are released, as they often have no access to health care or addiction treatment during a stressful and very dangerous time. Unfortunately, our current fragmented system of care causes many of these individuals to lose access to their health care benefits upon entering jail or prison, even if they have not been charged with a crime or are simply awaiting trial. So it's a cruel process. In practice, this can lead to significant hurdles in accessing care, as the process of restarting benefits post-incarceration can be bureaucratic and time-consuming, leading individuals to go without mental health or substance use treatment for weeks while they wait. We know that these delays in care can be deadly, as individuals leaving an incarceration setting are 129 times more likely to have drug overdose in their first 2 weeks post-incarceration than the general public. I've introduced common sense reentry legislation that would allow states to restart an individual's Medicaid benefits 30 days prior to release, so that we can improve continuity of care during this fragile period and provide a funding stream so that more correctional settings can offer high-quality mental health and addiction services, improving quality of care and reducing recidivism. There is so much more work that is needed in this space, and I hope that we leave today briefing with ideas on how to address some of the root causes of these disparities, how we can mitigate racial inequities in access to overdose treatment, and how we can reduce this disparity in fatalities. I know that everyone here today recognizes that we can do much better for our community, for our loved ones, and for our friends suffering with the disease of addiction. I urge all of us to listen, to learn, and to plan how we can act together so that we can in turn better address this crisis. Let me just conclude by saying this is an opening discussion with many to follow, because we certainly want to develop a plan of action. We know there's a lot of hurt, a lot of pain, a lot of inequity, a lot of suffering. We want to hear that, put it on the record, but it should not and cannot end there. We need a plan of action. So I look forward to today's discussion, and again, to our tremendous panel. Thank you for your time here today, for your passion, for wanting to make a difference, and certainly for your expertise. So, Yolanda, the show is yours.
So good morning. Okay, let's be in that good tradition of call and response. Good morning.
Good morning.
Thank you, fabulous. It's so great to see you. I know it's a Friday, and sometimes Fridays are sleepy, and certainly on the Hill, we know that Fridays are a time when members start returning to their districts to do that work that's so important to them with their constituencies. But we're delighted to have you here today to have this really important conversation. So thank you to Congressman Tucker for starting us off and helping to elevate the conversation, which is what we in fact want to have today, which is a conversation about this really pressing issue. We're a little bit technologically challenged. We had hoped that we would have mics on the table, so we're still going to try to figure the logistics of that out. So we did get them. Great, fantastic. We'll have a vote here. Oh, great. All right. So let's try that. We can all bear with each other. We'll be family today. Allow ourselves some grace. So thank you today for joining us for today's congressional briefing addressing inequities in the overdose crisis and how it impacts African Americans and Black Americans. This event, as Congressman Tonka indicated, is hosted by the Overdose Prevention Initiative at the Global Health Advocacy Incubator, in collaboration with the Congressional Black Caucus and the Addiction Treatment and Recovery Caucus. We thank both caucuses for their leadership on this issue. So as you've heard, my name is Yolanda Richardson. I'm President and CEO of the Global Health Advocacy Incubator, and I have the honor of moderating this discussion. My own personal background comes out of tobacco, and I spent much of my early career at the Global Health Advocacy Incubator focused on tobacco and doing so globally. So being able to have an opportunity on such a pressing domestic issue is really gratifying for me, and I'm glad to be in the room to have a conversation forward. Because today we want to address the urgency of the need to address the inequities and overdose deaths among Black Americans. So we've had some good news, as I understand it. Overdose fatalities, according to the CDC, have plateaued. However, when you take a closer look at this report, it shows that far too often, and as happens with other public health issues in America, overdose deaths have decreased among among white Americans by 3%, but the death rate for Black Americans has increased by 7.5% in 1 year. Behind these numbers, we know are individuals, families, communities, and the consequences run quite deep when loved ones are lost and the impact on the communities suffer. So studies show that although Black Americans and white Americans basically use drugs at approximately the same rate, the impact is different. Black Americans are far less likely to access evidence-based treatment, and according to the CDC, just 8% of Black Americans who died from an overdose had previously engaged with substance abuse treatment, while half of the white population had done so. Furthermore, we know the consequences of illicit drug use are quite severe in the Black community. We know, for example, that Black people are nearly 5 times more likely to be involved in the criminal justice system and be incarcerated for their drug possession as compared to their white counterparts. But the path forward is there. We can eliminate the barriers in accessing treatment, and we can increase critical harm reduction strategies and approaches, and we can end the cycle, should we all in this room choose to do so. But addressing systemic inequalities and injustices demands action, and it demands commitment. And so we're calling on everyone in this room, wherever you sit, particularly here in the halls of Congress, to help us to solve this crisis. So we're fortunate to have experts to help us have this conversation, and we are really committed to making sure that it's in fact a conversation. So we will take your questions at the end of the session after we hear from our really impressive panelists. So let me do a very quick introduction of them, but then they'll have the opportunity to elaborate more, not only themselves as individuals and the work that they do and the organizations that they serve. So let me start by welcoming and thanking for the participation Dr. Jerome Adams, Executive Director now of the Health Equity Initiatives at Purdue University, and, as we all know, a former Surgeon General. We also are here to welcome Tracy Gardner, who is the Senior Vice President of Policy Advocacy at the Legal Action Center and co-director of the newly launched, as I understand it, National Black Harm Reduction Network. We also have Dr. Kimma Joy Taylor, a pediatrician, and who is the founder of the Honor Consulting and a non-resident fellow at Health Policy Center at the Urban Institute. And finally, we have Bill Rutherford, Strategy Lead for Substance Use at the National Council for Mental Wellbeing. You can read more about your panelists. We have the QR code. You can have access to that by scanning the QR code, and they'll also have the opportunity to tell you more. So please help me transition to our exciting panelists with a round of applause. Now that we're all mic'd up, I'll take my seat and we will start today's conversation. So we're going to start with you, Dr. Adams, if you don't mind.
All right.
We transfer mics. Okay, fantastic. So as we all know, and as I just introduced to you, Dr. Adams served as U.S. Surgeon General, and so had the opportunity, as if speaking from this platform, to really raise issues around this issue. And the opioid epidemic was declared a public health threat under your tenure, and that was really important and catalyzed Americans' understanding of the issue. Can you explain what you've seen in terms of overdose deaths in America, and specifically as it relates to Black Americans?
I absolutely can. And first of all, I want to say thank you to all of you all for being here today. Thank you to Representative Tonko for your leadership. How many people from congressional offices do we have here today? Can you raise your hand? Okay, it's important for everyone to look around. We've got a lot of advocates here. We're preaching to the choir in many ways. But for you all, thank you for being here. I want you to take advantage of the people who are in this room, not just up on the stage. And I want to help you all get some context for why we're here today. But I just really quickly want you to know that this is an issue I prioritized as the pandemic before that other pandemic when I was Surgeon General. I put out a Surgeon General's postcard highlighting the actions we all needed to take to respond to the opioid overdose crisis. I put out a Surgeon General's call to action, the first one in 10 years, calling on more people to know about and carry the overdose reversal drug, naloxone. And this is also something that's very personal to me. My own brother is in a treatment center right now, about an hour and a half south of here in St. Mary's County, Maryland. I went to go visit him on Monday. Many of you know my story. While I was Surgeon General, my brother was in Jessup prison for crimes he committed to support his addiction. It's frustrating, it's hard. When you're a Surgeon General of the United States, when you're a physician, man, you can't help your own brother. But that shows the challenges that far too many people face. It also shows that it's going to take a community, a society, a whole society effort. It's going to take Congress and the White House. It's going to take Republicans and Democrats. It's going to take everyone coming together to solve this issue. So you asked me a very specific question about trends that I've seen. And I'll give you all 4 quick points. Number 1, this is incredibly important for people to understand. We are making progress. We had made progress from 10 years ago when I was here in this room talking about the opioid epidemic and its impact on rural communities. I was the state health commissioner of Indiana, and we had an HIV outbreak that was the largest in history related to injection drug use in Scott County, Indiana. That was a bellwether, if you will. It was something that really brought national focus to this issue. We are getting better. We're seeing overdose rates overall go down. We see more people know about the carrying naloxone. We see increase in treatment. We see more medication-assisted treatment available thanks to people like Representative Tonko. And why is that important? It's important for you to understand things are getting better because I live in Indiana. And at the ground level, many of our policymakers are frustrated because they feel like they're doing everything right and things aren't getting better. They see overdoses continue to happen. So we need to be able to reassure them that yes, the things we're doing are helping, we are getting better. That's important. Number 1 important trend is many things are getting better. The number 2 trend that you've heard highlighted is that not everyone is sharing equitably in this progress. Black communities in Indiana, we see that black and brown communities are disproportionately dying of overdoses. We know that young black men, age 18 to 24, it's the highest increase, and then for those groups in many communities, it is the leading cause of death. I was in Philadelphia a few weeks ago. The rate of overdose deaths in Philadelphia is one of the worst places in the country, y'all. And in one of the worst places in the country, you are 4 times more likely to die of an overdose if you're black than if you are if you're white. So, getting better, but not for everybody. That's the second trend. The third trend that is important to understand, and it explains why it's not getting better for everybody and why communities aren't seeing it, perceiving that it's getting better, is fentanyl. Fentanyl is a game changer. It is 50 to 100 times more potent than heroin, and it's increasing people's. So the average person injects heroin about 3 to 4 times a day if they're using heroin. If you're injecting fentanyl, you're injecting 8 to 10 times a day. And from a scientific point of view, the more you inject, the more potent that drug, and the more you're injecting, the quicker your addiction develops. So we're not seeing the progress because the game has changed. We're comparing apples to oranges. We have what we have is heroin policies for a fentanyl world. And for the folks in Congress, we need to understand we're going to have to change some things. We're going to have to change our opioid overdose reversal agents. So, for instance, Incubator is here. They have a new product that was approved last year called Advocacy. And why is that important? It's important because it was designed to respond to fentanyl, to synthetic opioids, whereas Narcan was designed in a world where we were talking about heroin. And you hear people over and over again saying they have to administer 3, 4, 5 doses of naloxone to reverse an overdose. But we know that the rules for prescribing buprenorphine and methadone, and we addressed those in the Modernizing Opioid Treatment Act, were based on a heroin world. And the initial starting points for buprenorphine, for instance, are so low that you're not even going to touch someone's addiction if they're addicted to fentanyl and with the low starting doses. But yet the DEA, in many cases, is going after doctors who try to prescribe doses that are appropriate for fentanyl. So fentanyl is a game changer. It truly is. And I can't impress this upon you all enough that we need to communicate to people that we can't use heroin policies for a fentanyl world, especially when almost 0% in most urban communities and many communities of overdoses now have heroin in them. Almost 100% have fentanyl involved. It is a different world. Final point I'd make, and this is a trend that we're seeing that's hurting Black and brown communities disproportionately and hit them first, was that no one is dying only of an opioid overdose anymore. There's a lot of polypharmacy going on. So people think that they're using cocaine and fentanyl is mixed in. People think that they're using methamphetamine and it's mixed in. We're even seeing it on college campuses like Purdue, where I'm at, an increase in accidental overdoses because of counterfeit pills, 60% of which have fentanyl in them. So polypharmacy is another trend that we're seeing, and we need to pay particular attention to, because we see in the Black community many people who were dying of fentanyl overdoses have no idea that there was even fentanyl in what they were using. They think they were using something completely different. I'll stop there, but I want you all again to think about this broader context. It's getting better, not better for everyone. Fentanyl is a fundamental game changer. Can't use heroin policies in a fentanyl world. And polypharmacy is an incredibly important part of what we're seeing now.
Thank you so much, Dr. Adams. That was really a very helpful beginning to the conversation. And I think I want to just now turn over to Hilma to just talk a little bit about sort of what are some of the health system failures. You've heard some of the big problems and big architecture around the issue. Tell us how the healthcare system may be failing Black and brown communities.
Thank you, and again, thank you, Representative Tonka, for having us. And I'm humbled to be here, especially because of all the experts I see and dear friends in the audience. So do talk to them afterwards. So really, historically, the healthcare system has failed Black and brown people in stuff. But particularly related to substance use, I want to talk, because we often say that, well, the healthcare system has chosen to incorporate substance use. And it's really important, actually, to recognize that early on this was not the case. It inequitably treated them. But back in the Civil War, morphine was used pretty much for everything. There were gunshots, wounds, for diarrhea, for dysentery, etc., for white people. Not for Black people, because it was deemed that we had a higher pain tolerance. So even if you had your foot amputated, you didn't need morphine. For diarrhea, we died at twice the rates during the Civil War because it wasn't given to us to stop it. So we actually had, and this was the beginning of another opioid crisis that was what we call iatrogenic, caused by overprescribing. So something should sound familiar: a healthcare system that took care of some people differently than other people, and a response that is going to be inadequate. At that time, there actually was morphine maintenance. And docked, again, inequitably, not for Black people, but for white people, not for Black, Indigenous, not for folks who are historically excluded, but for white people, because it was recognized that maintenance could help people take care of their kids, go to work, do all the things that they needed and wanted to do. Overprescribing it grew to a broader population of people who had the means, and then the Harrison Act came in 1950. And it was this really punitive approach. It was our early war on drugs. It was built off Chinese Exclusion Act. It's kind of like, let's take out as many people as we can. And with that, it was deemed illegal for doctors to prescribe maintenance therapy. And this is really important because we decided that having punitive measures was more important than saving lives. Again, inequitably saving lives, but at least you have a philosophy that you should save lives. And in this period, docs were criminalized if they provided maintenance therapy such as methadone. So to say that it was never part of the health care is not accurate, but it's also really dangerous because it abdicates the responsibility of our punitive policies that took it away from this profession. We've known for ages that that substance use is a chronic health concern, literally since like signers of the Declaration of Independence. So also the pretending like, oh my gosh, we just learned it's a chronic concern is dangerous and deadly as well. And so the healthcare system, and I do a whole other series on how the healthcare system has led to inequities and continues to perpetuate inequities among Black and brown people, but particularly in this situation, continued that dichotomy of who has access, who doesn't, up till this current opioid crisis. And I want to be really clear, we are in a current opioid crisis, but this polypharmacy has been around forever. And what we do is we treat particular drugs. Like then it was a morphine crisis, then there was a methamphetamine crisis, then there's like we actually need a substance use system, right? A substance use system, not one just for substance use disorder, but for people who use substances so that you can have as least harm as possible, much like we have with diabetes. Whether you have pre-diabetes, no diabetes, we respond to it, right? So we need a substance use system. But nonetheless, going to this one, our healthcare system has had structures in place, fundamental structures in place that have led to inequitable outcomes in this and other arenas. And those inequitable outcomes persisted here, even in the current opioid crisis, because similarly, it was iatrogenic. caused by prescription drugs, who has access and more access to prescriptions and to healthcare insurance, a particular population, and they're like, well, that particular population, again, white people, should have a response that is a little more warm and fuzzy. Drugs have been around forever. There was a punitive response before. So it's not accidental that there's more black people in jail. That was on purpose. And if you look at some of the early learnings of Nixon and his people, it was on purpose. When you look at the opiate dens and the San Francisco ordinances, ultimately the Chinese Exclusion Act, this was on purpose. There's a reason there's this dichotomy of who's in jail. And that's important to me because we're always like, well, there's this population in jail, we should treat them. Well, honestly, we should not have many of them in jail in the first place and then treat them in the community. But nonetheless, so the healthcare system then was removed and kind of gleefully was like, okay, then we don't have to take care of people who use drugs. And this is really important because if you don't realize this history, you're then like, let's put remedies on. And you can't be surprised that buprenorphine is prescribed inadequately, right? That certain people get it, certain people don't. And so the reason understanding, and I only have a little time, but the reason that understanding this basic lack of infrastructure of the healthcare system, how it's run, how it's funded, who has access to it, is important because then we do these remedies on top, and by virtue, they're going to have inequitable outcomes. By virtue, in communities, because we're excluded, done a lot of work in Baltimore, the Baltimore folks are here, but for instance, like harm reduction was because communities had to save themselves. Right? Black, HIV communities had to save themselves, created these networks of harm reduction that the healthcare system didn't accept. And now we're pretending we're going to just put it in the healthcare system and it's going to serve people ethically. No, we have to, so my last point, we have to listen to the people. The way you can change this and change the failure of the healthcare system is admit it's hard, admit we did it wrong before, be incredibly humble, and then listen to the people who actually can tell you this is what I need, this is how I've been failed before. We do this thing, well, people don't trust, there's a reason. It's not just this accidental, people aren't trustworthy. We actually tried to kill people. So being able to go out and saying, what is going to be helpful for you, and I think this is true for all healthcare aspects, but to say, what is going to be helpful can really help us to change the overdose crisis, because we're going to hear people need. We're going to hear that polypharmacy is around since, forever. We're going to hear that people need access to housing and food and justice and education and all of these other pieces. So the healthcare system has failed, but we as society help ensure that failure by creating this punitive approach and allowing that punitive approach to continue. And the last thing I'll say, and it's incredibly important for me, access is not the end goal. Outcomes, equitable outcomes. We talk so much about access. It is incredibly important. I'm a true believer in everyone having access to healthcare and equitable access to insurance, but it's about outcomes. I work in the healthcare system. You can have access and go in and get lindered up so badly that there are very poor outcomes. So I am demanding equitable outcomes for people who use substances to achieve wellness. And I use wellness across the whole spectrum of health and
Thank you so much. So that's great. We've had a chance to talk a little bit about the context that, sort of Dr. Adams has set up for us, and then Dr. Taylor really just talked about how the health system has failed us, but that hasn't been new at all to this particular problem and epidemic. We're going to take a pause right now because we have the benefit of having Congressman Lori Chavez. Dorima? Thank you. There she is. Come right up.
Well, good morning. I am Lori Chavez DeReamer. I represent Oregon's 5th Congressional District, and I'm grateful to be here this morning with a great group. When a lot of the Hill is going to start getting out of here after this last vote, I'm glad that you all are here to do the work and listen to the issues that are happening, and thank you to OPI for having this. In terms of health care, our communities have been at a disadvantage. In Oregon, the overdose crisis is the #1 issue we face, even greater than housing. Oregon ranks almost last in access to addiction treatment and near top in substance abuse disorders. It's why I have a healthcare first mindset in representing my constituents. Last year, I made sure to introduce the Direct Care for the Homeless Act, which targets the homelessness crisis by first addressing the overdose crisis. Homeless patients need to be met where they are. So my bill expands access to street medicine so that no one is left behind. that everyone and every person in the unhoused community can receive primary care. In the Education and Workforce Committee, I was able to attach my opioid crisis workforce action into the reauthorization of the WIOA, which has passed the House. This needed change will require the Department of Labor to share information on best practices with state and local areas struggling with substance abuse disorders, streamline the community's ability to apply for grant funding, and codify the Department of Labor's ability to award those grants for upskilling workers in the fields of addiction treatment and recovery. Frontline workers deserve this support from their government. There are some solutions, but it will no way end the nightmare that we are living through on the streets, not only of Oregon, but across this country. It's going to take these meetings and conversations, bipartisan. It doesn't matter the party that we represent when we're addressing this crisis. And it's going to include the voices of everybody in our communities. I'm incredibly proud to follow the leadership of Congressman Tonko, a force of nature in this space, and to share the room with you all today. As a former mayor, as a mom, and as a business owner, local is where these problems get solved. And if we cannot have these conversations and then take them back to our respective communities, we'll never get a handle on it. I'm very proud to be here. I'm very proud to represent my country, but this is an issue that all of us across America should be the number one issue that we're facing if we want to save the future of this country for our young people. And so thank you. Thank you for being here. Thank you for taking the time. Thank you, Dr. Adams. It's my pleasure. I know I haven't met a lot of you, but thank you for allowing me as a freshman member of Congress to be a part of this conversation. I appreciate it very, very much. Thank you.
Thank you so much, Congresswoman DeRimo. Okay, so back to our panelists. As I said, we talked about some of the large structural issues that we need to understand in terms of this issue and the specific nature in which the healthcare system has failed communities of color. We're going to move now to have a chance to talk about what individual substance users can do. I feel you describe yourself as a recovery coach, a passionate member of the recovery community, and your own self-described doctorate from the School of Hard Knocks. So I think there are a couple of us in this room that would also be in attendance with respect to that. But we wanted to hear from you about some of the things that you've learned as a recovery coach that communities face and how they can begin to deal with those.
Sure. Can everyone hear me okay? If not, I can yell. So thanks to GHAI and Congressman Tonko and the Congresswoman that was here. But thanks to all you guys. I want to say something first about the doctorate from the School of Hard Knocks thing. I thought that was glib, right? So it's on. I put it in my bio. And I have 3 daughters. They're all they're 20, 24, and 26. And my middle daughter told me that she identifies someone that puts that in their profile in like a dating app as a red flag. I don't know if that's a good thing or not. I do believe that I have a doctorate in that way.
I got a 14-year-old daughter that keeps us honest.
Right. So first things first, I describe myself as a person in recovery. I work with other men in recovery. And I think the very first thing that I want to talk about is reframing our understanding of the word recovery. Because in my world, and I went through a treatment system and I had access to resources that worked for me, and I was introduced to recovery and it took, right? Not at first, but with some trial and error, it took. But not everyone sees it that way. So like I said, I consider myself a member of the recovery community, but what that really means is that I'm both socially and environmentally connected to a group of people with a common aim. I don't see that as much different than being connected to a faith tradition or a civic group or a membership group. I'm with a group of people that are trying to pursue the same thing. But there are lots of people that aren't, and I'll probably tell a couple stories today, but I'll try and keep them brief. Some years ago, I was in a church working on a recovery center, and the recovery center happened to be in the church, but I was working there I think we were painting the wall or something. I was working with a gentleman who volunteered for the church. And so we're talking and working, and anyone that knows me, you talk to me more than 5 minutes, you're probably going to hear something about recovery, or at least my journey. And the gentleman I was talking to said, yeah, 10 years ago, I was addicted to heroin. And it's been 10 years since I've been addicted. And I was like, great, you're in recovery. He said, oh, no. He said, I'm saved. And for those of you here that don't know what that means that he was connected to a faith tradition, and his faith tradition that was sort of the centerpiece of his wellness. But I learned a lot from that, right? Because like in my head, that guy lived the same way that I did. We both volunteered in the community. We were active with helping other people, lived what I believe to be moral lives, but he had no interest whatsoever in being labeled as someone in recovery. And I think that's important, like as we're talking specifically about Black community, again, if you don't know this and you're in here, the faith community in the Black community has a little sway, right? So there are probably groups and networks of people out there that as we talk about recovery, we gotta get all these things in place, they're not getting that because they don't perceive themselves to be that. So that's thing number one. And I think the most important part of that story is just that gentleman didn't want it, right? But you asked about support, so I want to talk about supports. SUD, and I'm with Kima on the concept of substance use disorder instead of specific substances. I think we end up playing whack-a-mole sometimes with this substance, that substance, this substance. But SUD is really one of the more treatable chronic illnesses. As far as chronic illnesses go, SUD is you can treat it with actual clinical treatment. There are other interventions that are, medication is working. There are other interventions that work on substance use disorder. So why then is that not exactly translating to the Black community? And I think there are a couple of things. One is that the lack of culturally specific programming, culturally specific things that in the Black community are creating a barrier to people getting well. I think that stigma, and we're gonna talk a little bit about stigma as a little bit later, but stigma is a giant problem, both inside and outside. So both stigma from people looking at people with substance use disorder and people in the community looking at substance use disorder. So it's a challenge. I think there's also, and this has been touched on, a systemic lack of resources. I heard the statistic about 70% of the 70% disparity in buprenorphine prescriptions, and I think it was 77. I had a Yale study that said 70%. And another big problem is treatment completion. So treatment completion is a thing that we look at for, as you mentioned, outcomes, right? When we're talking about people that actually do make it into treatment, which, by the way, it's estimated that between 75 and 90% of people that meet the clinical criteria for substance use disorder do not ever attend treatment, right? So, but of that 10%, of that little group, which is less in the Black community, but of that group, treatment completion is much lower for Black people. And treatment completion it's hard to sort of understand all of the things, so I can't do direct causation with why Black people put out of treatment sooner. So I can't say that is exactly why, but there is a definite correlation. There's a statistically significant correlation of Black people being put out of treatment at a much greater rate. And that probably lends itself a little bit to some of the cultural specificity that's needed. And finally, I don't like the term social determinants of health. I prefer structural determinants of health. So the reason I don't like social is because it indicates that maybe that group or a society of people said, hey, we'd like to have less money, crappier schools, but crumbling infrastructure. So that's not how that happens, right? But the CDC describes the social determinants of health as non-medical factors that influence health outcomes. And there's so many factors that are already interfering with the Black community and getting specific treatment help we need to look at it a little bit differently. And I'm going to talk about reframing if I get another question. I don't know what my time is, but we need to be looking at housing, healthcare, insurance access, job opportunities. All of those things are the influence someone's ability to recover. And I know there are a lot of people in here that I know, and I know that you guys know what the word recovery capital means. But recovery capital is a measurement of the things that you have in your favor when when you get someone with SUD. What are the things that are in your favor? Like, do you have stable housing to go back to? Do you have food in your refrigerator? Do you have access to transportation? Traditionally, and I'll thank Dr. Bill Saint from Harvard on this, traditionally, Black people enter the SUD condition with greater recovery capital, but our outcomes are far worse. And I believe that to be about the structural determinants of health. So the supports, the same supports that like that 3% drop in the overdose rate, that tells me that something is working in white communities, that those interventions are working. The escalation in Black community for overdose deaths tells me that those interventions are working. And the thing, some of those interventions are pharmacological. And so unless you believe that Black people are somehow pharmacologically or internally different, those interventions will work for us too. Thanks.
I don't want to jump ahead, but I just want to highlight an important point that Phil made for particularly our congressional folks in the room, because it relates back to the three bills we're discussing: the Reentry Act, the Due Process Continuity of Care Act, and the Modernizing Opioid Treatment Act. Phil said that substance use disorder is one of the most treatable chronic diseases out there. I want folks to understand that. If you treat substance use disorder appropriately, you have rates that are equivalent to treating hypertension, high blood pressure. You have rates of success that are equivalent to treating diabetes. But if you don't treat them, then people aren't going to get the care that they need. They're not going to be successful. And a lot of the stigma that exists out there is because people say, well, so-and-so went to treatment and it didn't work. Or we're not perceiving that this is actually having an effect. Well, it's because we aren't giving everyone evidence-based treatment. If you don't give me the right treatment for my high blood pressure, then it's not going to work. If you don't give me access to the appropriate care and resources I need to deal with my prediabetes, and I have hypertension, I have prediabetes, it's not going to work. Same thing for substance use disorder. And it's why we need to make sure people have access to medication-assisted treatment. And we talked about the Modernizing Opioid Treatment Act. If they don't have access to the medications, they're not going to be any more successful than treating my blood pressure. And the Process Continuity of Care Act and the Reentry Act are about making sure people have access to Medicaid, because you can't get your treatment if you don't have a way to pay for that treatment. And so I just wanted to drive that point home, particularly for our congressional offices in the room, that all this loops back to the point that Phil made, that we actually can treat people who have substance use disorder, but we have to make sure these systems are in place, the structures are in place to allow that treatment to occur.
Thank you so much, Dr. Adams. Thank you, Dr. Bill. I'd like to acknowledge Congressman Madeline Dean, who's just joined us, so thank you so much for your participation today. Okay, so we've talked a little bit about, and Tracy, when I introduced you, I indicated that you are the inaugural director of the National Black Harm Reduction Network, and so we really wanted to hear from you about how do community support, what do we need as communities to approach drug abuse and substance use in the ways in which have been illuminated today.
So again, like everyone else, thank you very much for this opportunity. It's giving me a little bit of a flashback. I did an internship at National Minority AIDS Council back in 1991. But we were talking to the Congressional Black Caucus about HIV and AIDS, and there's a lot of, so much similarity. And there are some folks in the audience who were around. We've kind of seen this arc. And so there's some similarities that I think are worth noting. And one of them is about leadership, right? So when I think about congressional leadership in particular, and I start with our own Congressman Tonko, but Waxman, Kennedy, Harkin, Wellstone, Dominici, This is Ryan White Care. This is the Mental Health and Addiction Equity Parity Act. You've got to have champions. And so part of the drive to develop the National Black Harm Reduction Network is because we don't have champions. We don't have Black leadership championing this issue, addressing the stigma, talking about the impacts and kind of why we are where we are. This is certainly not the first health emergency that has disproportionately impacted Black communities. And if we don't address some of the issues that Dr. Adams and Dr. Phil and Dr. Taylor are talking about, we're going to continue, because we have a system that responds to acute and emergency and most expensive, and we don't invest in those strategies that are more sustained, more preventative, more organic, and more evidence-based. But the network, this was started actually 20, 30 years ago by Black people doing harm reduction work during the HIV epidemic. And harm reduction came from drug users for drug users, because the systems of care, health, and addiction treatment absolutely rejected and reviled people who use drugs. They reviled their families, they reviled the children of these families, and so people directly impacted had to come up with the strategies. I lost my childhood friend to HIV and AIDS in 1985, and that was the revelation for me about the resistance that we have to talking about sex and drugs, behaviors. I don't like the term behavioral health, by the way, because then we should include all of the behaviors that impact our health and wellness. But I get it, it's an easy way to talk about health issues of the mind as not such a big mouthful. So we started the network to address not just the lack of attention to the disproportionate impact of overdose in Black communities, but the interconnecting factors that drive it, which include, obviously, the health disparities, which include impacts on from the war on drugs. Dr. Phil has taught me that if we look at the historic clock, chattel slavery was half an hour ago, and the war on drugs was 2 minutes ago, relatively speaking. And so the impacts we are feeling today. And what's critical is if we don't take some action now, we will perpetuate those inequities driven by those policies, and we will have even more to contend with for our future. Certainly the case could be made that HIV and AIDS and its impact on Black communities is inextricably linked to mass incarceration. I think the new Jim Crow really talked about that and really helped people understand that 80 to 90 or 75 to 80% of people who are incarcerated with mental health and substance use issues is not an accident. We have criminalized health issues of the mind. So the network is really, we are going to be focused on cultivating, uplifting, calling out our champions. We want to talk about the interconnecting systems of the criminal legal system, of the family regulation system, and how those impact of inequities in healthcare, and how that is driving drug policy and criminal justice policy. And we are hoping to work with Black communities around this country because we say everywhere there's a MLK Junior Boulevard, you're going to see this convergence of these health disparities. And so we are going to be working regionally and with leaders in the community who are interested in advancing health and wellness. And so that is really about, when we talk about harm reduction, and we like to talk about seatbelts as harm reduction, we like to talk about, I think Black people in this country have had to employ strategies of harm reduction for a very long time in very different ways. Anybody know the Green Book? The Green Book is harm reduction. And so, again, we know that the resiliency and the strength is in communities, but we, for the network, we truly believe it has to be by us, for us. So the strategies that have been advanced, including issues around medication for opioid use disorder have to be understood in their historic context, have to be delivered in a way that community sees it as integrated, sees it as advancing its health. And we also need to engage the next generation of advocates, healthcare professionals, and of social justice entrepreneurs to embrace this highly stigmatized, but again, highly treatable, and we can address the overdose crisis. The last thing I'll say is all drug use is not substance use disorder. And Dr. Adams pointed out about fentanyl in that you don't have to have substance use disorder to be at risk of dying from a fentanyl overdose. I would argue that we have an addiction treatment system built to respond to crack in the midst of a fentanyl overdose crisis. And that is also what we're struggling with. Thanks.
Aren't you so happy you spent your Friday morning here?
Yes.
Great, thank you. So I want to stay on this conversation about community-based approaches, particularly to harm reduction. And I want to come back to you, Dr. Adams, to talk about something that you were a strong proponent of, which was of safe syringe programs when you were at the Department of Health in Indiana. Can you say a little bit more about that and why you thought that was an effective approach?
Absolutely. Congresswoman Dean, would you like to just say a few quick remarks to the audience? Because again, this is something that's near and dear to a lot of the struggles that you all are having in Pennsylvania.
Exactly. I was going to ask a question. I'll say a few remarks.
Please come to.
I'm delighted to be here with all of you. I know most of you on this panel. My name is Madeline Dean. I'm a representative from suburban Philadelphia. And so all of the issues that you are talking about today, as you all know, are near and dear to me. I have a son, Harry, our middle son, who is an opioid addict, and he is 11 and a half years in long-term recovery, and I'm very relieved for that. But I've learned so much in our struggle to decide what was wrong with Harry. And I think of the anger at the time, the anger I felt toward him and toward what is going on. But I've had time and the chance to learn from Harry. And I want to just say this to you, something that stuck with me, that Harry, as a high schooler, college student struggling with addiction, talks about the number of run-ins he had with the police. He talks about the number of run-ins that he and I had where I was trying to deal with his physical health. And he said something to me that has stuck with me. He's a white kid from the suburbs of Philadelphia, and he was treated unfairly fair. We need every person struggling with addiction to be treated unfairly fair. That's my belief. And so I'm mindful, I'm going to see our new mayor, Sherelle Parker, who's a colleague of mine. I served with her in the Pennsylvania House for 6.5 years before she went on to city council and now Philadelphia mayor. I'm a big fan of hers. But you see what's going on with the epicenter in Philadelphia of the hurt, of homelessness, of mental health struggles and addiction struggles with Kensington. I've been there many times, been there with my son, Dr. Phil, as you know. And you were talking about harm reduction, and you were talking about safe syringes. Give me the message that I should take to Mayor Sherelle Parker to make sure that we administer unfairly fair treatment to all, that we stop stigmatizing those who are struggling with drug use, addiction, or whatever you want to call it. What should I say to her when I see her Monday night? Thank you. And thanks for letting me say that.
That's a fantastic segue. Again, we've got some new folks in the room. Before I was Surgeon General, I was Health Commissioner in Indiana when we had the largest HIV outbreak in history, U.S. history, related to injection drug use. And we had to implement a syringe service program in order to help stem the tide of that HIV outbreak that was going on. And so speaking about that specifically, you've heard the conversation harm reduction. And harm reduction is a broad category, and it involves more than just syringes. It involves naloxone or Opvee, opioid overdose reversal agents. It involves fentanyl test strips. It involves clean syringes. It involves supervised injection. And for those of you who haven't had a chance, particularly those who are members of congressional offices, to visit a harm reduction program in your community, please do. I visited harm reduction communities in sites in Canada, in California, in Colorado, and I helped open up one in Indiana. And I can tell you, if you've seen one, you've seen one. And so you literally need to visit them and find out the different types of services they offer, the different types of people who come in and out and utilize those services, and understand that it's going to look different in every single community. In rural Scott County, Indiana, our syringe service program looks very different than a syringe service program in Kensington that I went to go visit. But also important to remember that harm reduction is incredibly important. From a policymaker standpoint, a lot of what they're hearing is they focus on the individual and focused on, again, reducing the harm to that individual. But what I try to emphasize is that harm reduction sites are bridges to care. They're bridges to hope. They're bridges to recovery. They're places that help build that recovery capital that you heard Dr. Phil talk about. And I'm going to keep calling you Dr. Phil because it sounds good. But what I will tell you in Indiana, and I'm unique because I come from a conservative state. I worked for Mike Pence and Donald Trump. And so I have to speak in a way that resonates with policymakers who are in the communities that I am in. And I don't think we do that enough. For us in Scott County, it wasn't about syringes, even though it was a syringe service program. We opened up what we call a one-stop shop, where we provided an array of services for people to build that recovery capital, and we focused on those. So you ask, what can they do? Well, they can increase deaths, or decrease deaths, and they can decrease infections. The evidence is clear that syringe service programs do that. I'll also tell you all a little secret. In conservative America, folks don't care about that. They don't. In many cases, when you're in the Bible Belt, they see death and infection as the appropriate sequelae for you engaging in bad behavior. And that is just the reality that we have to deal with. So here is how and you heard a lot about different words and words people like, don't like. We got a code switch. You got to understand your audience. You got to speak to your audience in different situations. And here is what I emphasize to get our syringe service program legalized in Indiana. Number one, we went to the jail, and the sheriff talked about the revolving door there. And so we focused on what we were going to do to lower recidivism rates, to turn off that spigot in the local jails. And our local sheriff became one of the biggest advocates for an expansion of syringe service programs. We talked about decreased syringes in the streets. And a lot of people in communities are worried it's going to increase syringes in the streets. But a syringe service program and highlighting the fact that we give a place for people to bring back dirty syringes actually has been shown to lower the amount of syringes in the streets. Because the average citizen, again, particularly in conservative America, they're not worried about decreasing the hepatitis transmission in persons who inject drugs. They're worried about their kid running into a dirty syringe and actually getting hepatitis on the street. So showing that you're decreasing syringes in the streets. Showing that you're actually increasing people's access to treatment. That was the number one thing that we were able to show to our policymakers that helped encourage them to continue to support syringe service programs. Everyone who came in was offered treatment. We tracked the numbers. We were able to show them that this many people who came into our syringe service program were actually getting connected to treatment. That is incredibly, incredibly important. Someone came in when we had a renewal, a sunset provision and a renewal. Someone came in and talked about all the syringes that they passed out down there. It was a community advocacy group. That almost undermined our whole program because our legislators didn't want to hear about how many syringes had been pushed out into their community. They wanted to hear about how many people had gotten into treatment and recovery, how many people were no longer committing crimes in their community. Two other important points in conservative communities: tracking metrics related to cost. So latest numbers from New York, it costs about $200,000 a year to incarcerate someone. That number is going to vary by communities, but almost in no community across America.
That's state prison. In the city, it's $450,000.
Wow. And helping connect what you're doing to that cost for policymakers is incredibly important, but we don't do that. We talk about infections, we talk about deaths, which are important. They are important, but when you're trying to convince a policymaker, you have to show them that, hey, we're going to lower your cost over here. They can help staff the factories and restaurants and become, again, members of society that are contributing. That is incredibly important too. So those are the things that I want to challenge you to think about when you're thinking about syringe service programs, because we tend to think about true harm reduction for the individual, because we're public health people, we're physicians, we're folks, that's what we care about. But when you're trying to talk to policymakers, you've got to help talk about the greater societal benefits. And in many ways, those societal benefits aren't at all related to health, of incorporating harm reduction and syringe service programs into your communities.
Thanks.
Okay, great. I'm going to hand it over to Congressman Coffman.
Thank you, Yolanda, and thank you again to the panel for a really informative discussion. And as I told you earlier, I had to go vote. So when I went over there, I saw Yvette Clark, who you're going to hear from in a minute, and she was anxious to come on over. But let me just thank Madeline Dean for having appeared today, because she's been a great active member of the ATR caucus as one of our vice chairs. And as you heard, you know, this hit home for many. Harry's story is a powerful one, and it hits home for Madeline, and I give her a lot of credit for telling and sharing the story and wanting to really make a difference. Speaking of wanting to make a difference, I just want to introduce to the group, for those of you who don't know, the Congresswoman Yvette Clark, fellow New York delegate in the delegation of New York, but more importantly, a true friend who I've known for a long time. She was an assembly member that I was close to, Robert Clark, way back when, and Beth has really poured herself into this issue and knows that these stats are real and wants to make a difference. And so I want to thank the Black Caucus for co-hosting with us today, and Yvette is their first vice chair. And so introduce Yvette Clark, Congresswoman Yvette Clark from New York.
First of all, let me thank our very distinguished panelists for being here and sharing with us the knowledge that we need to really combat what has become an overwhelming challenge for many of our communities. Dr. Adams, it's great to see you once again. We have had these conversations previously, but we're in a space now where our rhetoric is not enough. Clearly, best practices have been established across this nation. It's time for us to understand that we need a paradigm shift with respect to the mentality around substance abuse and treatment. I have thought about the fact that so much of what we are facing as a civil society has to do with the fact that we have not been good at elevating our interests and shifting out of a 20th century mindset, so that our healthcare infrastructure is a pitch and patch of treatments and activity that has not yielded us any better health in our civil society. And this is a health issue. And I believe that we need to be looking at what a comprehensive therapeutic healthcare environment looks like, so that our family members, our communities feel comfortable, have gotten into a habit and a practice of embracing treatment and health. There's a lot of the challenge that, particularly in Black communities, we face as families is stigma. And the stigma will hold back a family member from finding pathways to treatment for a loved one who may be in a situation where they're abusing substances that are leading to, their demise. I want to again thank you, because you are bringing state-of-the-art treatment, therapy, understanding to our communities. And it's up to each and every one of us to be advocates for a paradigm shift. We cannot take a broken system and try to apply new methodologies within that system and think that it's going to be embraced. So on behalf of our chairman, Chairman Stephen Horsford, Chairman of the Congressional Black Caucus, and our 60 members in the House of Representatives, let me express our gratitude because you're on the ground, you have the lived experiences that make policy real. And we need to embrace it and get others to become far more enlightened around the fact that this is not a political issue. This is the lives of the people that we represent in our communities across the board. It's someone who is struggling with substance abuse does not give up their citizenship. They need our help. They need our guidance and they need our support. So let me thank you, Paul, for bringing this together, the team behind Paul who has made this possible, and to our very distinguished panelists, once again, thank you for all that you're doing to lift us up. As a New Yorker, you know, I know that we can do better. And if, again, we are enlightened enough to look at a new paradigm, we don't have to spend that kind of money to create a therapeutic environment within our communities. We have the campuses, we have the wherewithal, we have the talent, the expertise. We can make it happen. So to each and every one, once again, thank you. Have a great weekend, and thank you for Tonko for your
So thank you, Congressman Clark, for that and the need for a paradigm shift. I think that's what our conversation today has very much been about. And looking at
I'm sorry, I just wanted to add one more thing. This is an ongoing conversation. This cannot be a one-off. We have got to continue.
So we know that these conversations all take place in a real political context, and some of the times that we can motivate Congress when we talk about our children. That's a shared thing. So I want to turn to you, Dr. Joy, to talk about, you're a pediatrician, you've seen the numbers, you've seen that 15 to 24-year-olds have an 86% increase in overdose mortality. So from your perspective as a pediatrician, what are some of the things we can do on the preventive side of this?
Absolutely. And again, I would argue that the health system needs to do better on prevention overall. But from the perspective of prevention in this space, I really want to first stress it's not just about programming. So I'm going to go big to small. In the sense of, one, kids need to feel that they belong, that they care, that people are in part of enjoying in their well-being. And I'm doing some work actually now in Healthy Schools campaign about what kids say in terms of what they want for prevention in their schools and their lives. One big thing that comes up is honesty. Tell us the honest truth. Don't have us go to assemblies where people say one puff of marijuana that leaves you paralyzed for the rest of your life, because they know, for instance, where it hasn't. So having a safe, honest place to go. And people are always like, well, kids are in school forever, so let's do it in the school system. So that gets me to the next one. And Phil uses structural, I use societal in terms of health, because society can determine how we want to prioritize people's well-being. And in this space, schools is the societal determinant. You cannot say we're supportive, warm, fuzzy environment when you have these incredibly punitive laws in place. And so, for instance, for my kids' school, they say, well, we're going to have blocks in the back of the room, but anyone who's possibly thinking about using drugs will be expelled. That kind of dichotomy is not going to improve well-being. So really thinking on a broad level about school climate, how you create climates that make people feel better about themselves. Having caring adults. One of the things that came up, even when you're doing programming, people are teaching the programming, having people care about the students. And this is another thing that I think leadership is so important, as Tracy was saying, leadership from the CBC. In schools, often our kids are told what they can't do, how they can't succeed, well, you're doing well enough or whatever. And so particularly for Black youth, having champions that say, we know you can do it, we love you, and we're going to help you get there. And those caring adults who actually know the subject matter. And it's important to say, so that might not be who you usually pick, the PE teacher, right? It might be the coach, it might be the maintenance person, it's whoever those kids trust. You don't get to dictate who kids trust, especially if you created an environment that's often trustworthy. When it gets to programming, something that came up before is, even if you have programs, you need a diverse workforce. Again, we do a lot of work in workforce diversity, but it needs to be diverse, and that has to be inclusive of the peers. Young people listen to young people, and it's peers as they define it, right? And so in all of this, it's getting together with youth, common theme, and saying, what do you want? What does it look like? Who do you define as your peers? Can't just be the student of the board, right? It has to be all of the kids and all of their diversity, LGBTQ+, different ages, different abilities, has to be a monopoly of folks that come together and having peers, and then in the broader workforce, having people that look like them. And then ultimately, saying, what does well-being look like for you? This is a conversation about prevention, primary prevention, but it's also secondary prevention. A lot of kids use drugs who do not have substance use disorder. It is, and people writ large, but we're not going to consider. So providing that secondary prevention that we often call harm reduction here, but in other spaces called secondary prevention. So you use, now what? Again, not that I'm expelling you. How can we make sure that use is less harmful? I talked to this one youth who was like, well, I was really thoughtful, and I was using fentanyl and marijuana, and I decided to stop using fentanyl. For many people, like, well, you missed the boat, you didn't stop altogether. That's a win, because as Dr. Adams said, fentanyl kills, right? And so understanding that and having a safe place that people can go, and getting then to all of the other pieces, the things that these youth said over and over is, ask us why we're using, and help us to address that. Nobody asks. You tell, ask us. And so at the end of the day, I think for most of the endeavors we do, talk to the people you're trying to serve, recognize prevention is about people feeling good. And that's, I mean, like, even when we were talking and I like kind of pushed you out the way because I saw a friend of mine who cares about me, loves me, and is always there for me, that's what you need. It was a soft push. Okay. No, but because that's what you need, and that's what young people need, and that can be after school activities and other things. So don't just focus on programming, focus on the whole environment and societal structures.
I love it, thank you so much. So that's age-appropriate sort of services. Can you talk, Phil, a little bit about culturally appropriate services and how they support or don't support people?
Yes. Absolutely. And I have a whole list of things that I wanted to talk about around culturally responsive caregivers and the like, but I just, in lieu of that, I just want to share some of my own personal experience. My recovery journey was, I mentioned that I found treatment and got help and all that, but the road was a little bumpy to get there. But the single most significant fact in my recovery experience was connecting with someone that looked like me, understood what I had experienced as a black man in America, and had a pathway out, right? So the thing is, I went to a lot of places, and there were plenty of people that told me what I needed to do. And this gentleman said, you know what, I know what it's like, I got you, right? And something about that really worked for me. And I've seen it work in many cases, and even some kind of tough luck cases where people, we thought someone was going to pass away, but they got connected with culturally appropriate caregivers. Now here's the thing, you can't have culturally appropriate caregivers if those folks are not matriculating through some sort of education and getting to a place and working in a facility where they can provide that care. So one of the things that I'm interested in from a resource standpoint, and I respectfully, the Congresswoman that spoke earlier, I think we do need a massive infusion of investment in this system if we want to make it work. Tracy mentioned Ryan White. I want that. And actually, I'm kind of a nerd, right? So I was looking at what $100 billion in today's money would be. So the staffers in the room, don't freak out, but about $243 billion is that. But that investment, so if you think about where HIV was and where HIV is, it's not fixed, it's not perfect, it's not cured, but we've made a lot of progress there. Why can't we make that sort of investment in people that are dying at 100,000, a clip of 100,000 a year? So and part of that, and I'm not suggesting that all of that needs to go to one particular community, but that sort of reimagining of the way that we provide treatment, all of the research, a lot of money in Ryan White went to research, all of the things that happen there, why wouldn't we do that for this public health crisis, right? I don't know why we wouldn't. But so if you're a staffer here, I also run an organization called Black Faces, Black Voices, and if you see an appointment request from us, you'll know why. Because we are devoted to trying to drive resources into community in a way that isn't currently being done.
Thank you so much, Phil. We're going to open up for questions, but before we do that, I wanted to just turn to you, Tracy. Just talk a little bit about, Phil has emphasized the importance of resources. You've worked so long and so deeply around health equity questions. We got those kinds of resources. Tell us how we make sure that they're going to be addressed, the problem in an equitable way.
You know, I had some remarks to respond to that, but instead I want to go along or take advantage of Dr. Adams being here and the critical importance of being able to, we're preaching to the choir for the most part. How do we code switch? How do we adapt our language in ways? When you said that there are folks, and I believe that that is part of the issue about the challenges that we have in the Black community, in Black communities, that we can love the sinner but hate the sin. But if you continue to sin, that's the wages of sin, are death and destruction. So how do we talk more about what is bad and what is not bad, but similar? So as I thought about, we talk about diabetes, we talk about lung cancer, we talk about heart disease, we talk about, Phil and I like to talk about the fact that overdose prevention centers are bars and restaurants. And Phil talks about what happens when that bottle of a poison bottle, contaminated bottle of Jack Daniels. What would happen? How do you, we would have a whole process to identify that bottle of Jack Daniels. We would know the distributor, the manufacturer, and there'd probably be a big lawsuit. And that's also why when we talk about opioid settlement dollars and this opportunity that we have to reinvent how we address people who use substances and ask and build a system that answers why people use. So, you know, Medicaid reentry is one of these huge issues that I've totally walked out on for the last 15 to 20 years, because people with HIV who were formerly incarcerated are the ones who taught me that the interruption in Medicaid as they re-entered was kind of the single most disruptive thing. And so from that, we have talked all about transition care and the fact that Medicaid for almost 60 years has made us create workarounds to ensure or understand that community health, correctional health are inextricably linked. And again, back to our policies of mass incarceration. Incarceration makes us all sick, right? But I definitely think that it's important that those of us who've been doing this work for a long time learn how to talk across the aisle. And so I appreciate the challenge of how to talk more about what the common welfare should be, right? And this idea that if Black America is catching a cold, the rest of the country is at risk for pneumonia. And we saw that with COVID.
Thank you. Thank you.
I know, I just want to highlight one more thing really quickly. I think that we also have to make a concerted effort. When we have conversations like this, and it happened today, it happens at every single one, we're tempted to tell the terrible statistics, the overdose deaths, the increases in overdoses, the bad statistics, but we don't focus on the stories of recovery. We don't focus on people like Bill and their story. And I think my challenge to you all would be, every time you have a bad statistic, share a positive one. Every time you have a negative story, to make the point, and they are important, they stick with people, you share a positive one. Because the problem with all the negative stories is it creates this insidious feeling amongst folks that there's no hope. that there is no hope. And so you have to help people understand, to your point about trying to reach across the aisle and trying to show the societal benefit, that hey, but we actually are making progress. We actually do know what works. And if we then implement what works, we'll have more of this and less of this. I think that is a key, and that's something we've got to do a better job of in terms of our messaging. It's not just trying to, you talk about kids, scared straight, just say no. You can't do that alone. The statistics matter, and you don't want to ignore the bad, but you also want to couple it with, and here's what we can do in a positive way to help move forward.
Thank you so much. I think we have time for 2 questions, perhaps. Let me just suggest it would be fantastic to hear from folks who are in congressional offices who want to really understand what they can be doing to make a difference. I know advocates are dying to also ask some questions, but if they're from the congressional staff, and it would be great. So I can just take 2 questions, unfortunately. Okay, please, go ahead.
Okay. Me? Oh, okay. I wanted to yield to what you said with regards to the congressional staffers. I'm not. So if there is anyone.
Go ahead.
Okay. So it's kind of a question and a comment to Dr. Adams. I am Dr. Smith Wilson from Friends of Recovery, New York. You don't necessarily know me, but I am friends with Dr. Phil and Tracy. I'm playing. They didn't know I was going to be here. My question, comment to you is, you made a very good point with regards to the cost connection. And I have not an issue, but a concern with regards to that. I work on behalf of a lot of family advocates, right? And so when you equate a cost connection, that becomes an issue, right? Because individuals have lost someone, and what is the cost of that, right? And so, getting back to what the Congresswoman said with regards to the shift, what studies have found that the actual reduction in stigma is the connection to humanness, right? It is that human-to-human connection as you describe and compare an individual who is in the life of addiction or whatever the case may be, that actually reduces stigma, which could in fact have an effect on someone's behavior and policymaker. So I would say that what my question is how do you address the families and individuals who've lost someone as they try to build this political agenda, build this political platform in order to get more services, who will be very upset about the cost connection?
That's a fantastic question. And one of the things that I say, not just in regards to this issue, but in all public health issues, is we need more and better communications training. And what you're talking about is communications 101. Is you bring them in with the hope, with the story. And I don't do this, I wasn't playing you all, but you notice I started off talking about my brother and my personal story. And then you weave into the statistics. And the statistics have to be something that resonates with the people who you're talking to, just as the stories have to be something that resonates with the audience that you're talking to. So what I was saying was not or, it's and. It's make sure you're sharing those stories. That's what sticks with people. They remember hearing from the person who was incarcerated, from the family member of someone who lost someone. Make sure you have that story, but make sure you're coupling it with the data that is relevant to the person who you're speaking to. And you also have to understand that the stories that you tell and the data that you present in Boston is going to be very different than the stories and the data that you tell and present in Boise. And that was, again, the point that I was making, that in Indiana, and I've had this conversation with people in Philly and in New York, I'm just telling you all that the way that you're telling a story isn't convincing a Southern Indiana legislator to pass a policy to expand harm reduction in their community. And you have to think about that. So I appreciate what you're saying, and I agree with what you're saying. And you never, ever, ever want to forget about the families and the individuals. It's not or, it's and.
And to your point, what we create is constituencies of consequence, right? So we don't want the legislator to have a bleeding heart We want them to understand the dynamics, and so we, voters, right? That's, at the end of the day, that's what we fall back on. Families are voters, that's all.
Can I ask one thing? I just want to, stigma is involved in this, right? And one of the things, like I said, I'm a nerd, right? And I actually had a whole thing prepared for you guys about cost of sobering centers and all that. I won't bore you with the details, but the math is good. It's a good policy. Okay. One thing, and in my previous career, I did like lots of corporate sales stuff, right? So they teach you about objection handling there. And to the relevance to what we're talking about here is sometimes I'll encounter a legislator that the argument is it's not fiscally responsible. I'm not paying to give these dirty so-and-so's drugs. I'm not paying to give them syringes. And the fiscal argument can at least unpack the objection. That's what they teach you in corporate sales schools. You have to unmask the objection. You got to understand what the real objection is. A lot of times that is a smoke screen. A lot of times it costs too much and we're not paying for this and all that. That is sometimes a smoke screen. Now that doesn't mean that it always is, but having that, being able to sort of debunk the myth that substance use disorder treatment is more expensive than incarceration, emergency room visits, which that's ridiculous on its face, but that is sometimes the objection that people have. So it is, to your point, it is useful, not necessarily with families, but if you're trying to understand what the real objection from a policymaker is, we at least can get that out of the way, right? So that's all.
This has been incredible. Did you want to add something?
There's a question.
There's a, okay, one
Good
question.
question.
Can you please stand and give your question?
Good morning. Thank you to all the panelists for being here today. My name is Jamal Shepard. I'm a policy advisor in Congressman Bowman's office, covering healthcare. Mr. Rutherford, your point about the response from the Black community and the cultural stigma in relation to recovery and the response is that, no, I'm safe. That really resonated with me, as someone whose family also grappled with that stigma, with people who are suffering from substance use. How do we build that bridge in building trust within the Black community, with both the recovery community and like culturally competent healthcare workers, to start to deliver better outcomes, and building that family support, because we see how the lack of support around an individual when they're suffering from substance use, and sometimes abandonment from family can result in worse outcomes than if they have a community behind them and the appropriate healthcare providers.
I think that the very first of all, thank you for your question, but specifically around stigma in Black communities, and this isn't a plan, but at Black Faces, Black Voices, we do these things called unity dinners. And the point of a unity dinner is to bring together people from the Black community, people in the faith community, community activists, harm reduction people, recovery folks, and put them in a room and talk about this, because I don't think any of that stigma there's no magic thing for stigma, right? There's not some dust that we can sprinkle on stigma and make it go away. It has to be done brick by brick, block by block, person to person. So having those discussions, and we on these dinners, we partner with Black Harm Reduction Network, and we get people to have the discussion. Why? What is it that troubles you about handing out naloxone? We had a situation in a community in Chicago where the church was 100% ready to support everything that we were talking about until we wanted to put a naloxone box outside of their door because it would bring those people.
Yes,
And the thing is, overpolicing, mass incarceration, cocaine, all of that has affected the Black community in such a way that sometimes people are resistant to things like harm reduction. And what happened in that particular situation is we got people together and talked, and from a biblical perspective, we had someone explain why it probably is the right thing to do, because you might save a life, right? So, but that doesn't happen if we put out a congressional program to stop stigma.
Yeah.
That happens in community, across the table, over a plate of greens, well, not greens, but whatever. I don't want to lean into the stereotype, but I'm just saying, like
Now we get into blood pressure.
Okay. Someone offered me vegan greens, but anyway. But having that stuff, having that kind of belly-to-belly work is really important, and the challenge is that it still requires resources. I'm not saying that we can do that for free, because sometimes you're like, great, y'all folks go sit in a room and have dinner and talk. It still takes resources, but that's the only way we're going to address that problem. I don't see any other path out. You got anything in that?
Just the final thing, and I sometimes hate this phrase, this term, but everybody can relate to the fact you cannot achieve recovery if you are not alive. And so that is why Black people in recovery and Black people doing harm reduction are not at opposite ends. We're part of a critical continuum. Black people in recovery are not anonymous. And Black people doing harm reduction want to save lives. And Black people in recovery want to save Black lives too. So this is the work that you can expect from us moving forward.
Thank you for asking that question. Thank you for being here. We couldn't have ended on a better note. It does my heart good. I come to DC a lot. I go to congressional offices a lot. I don't see people who look like you a lot in those congressional offices. And I make that point very specifically because look around the room. Even in this room, we need more representation from the people who we are trying to help. And whether you're in a nonprofit group or an advocacy group or a congressional office, I would challenge everyone to do more to make sure we have particularly the young voices coming here to DC and being part of the advocacy process. I'm at Purdue, and every time I go into my congressional offices, I say, well, why don't we have more interns in the offices who look like we do? So thank you for being here. Thank you for asking that question, and everyone else, do what you can to make sure we have more people who are representative of the communities that are being disproportionately harmed by any array of health factors in Washington, D.C.
Thank you so much. I have three things that are separating you guys from lunch, so let me go through those three things. Let me first ask you all to join me in thanking this phenomenal panel. Let me secondarily remind you that the strength of this conversation today is a reminder that this is the first among many conversations that we need to be having. How do we build the messaging? How do we build the political support? How do we make sure that once we have that political support, it's used to deploy resources in a way that are the most effective? So that's my second message to you. And this last message I would leave to you, taking up on some of the messages that everyone said today, is that we all are deeply human. We all start from a place of humanity. So I want to just reinforce the importance of talking about the statistics, but remembering what you, Dr. Adams, says, also creating a sense of possibility.
Yep.
So thank you.